Thank you for inviting me to come and speak about the patient preferences and experiences regarding the thrombopoietin receptor agonists for ITP in the UK and Ireland, otherwise known as the Trapeze study, the study which some of you may have taken part in. So the background to undertaking this study was really to get a better idea and add to what is quite scant literature about the experiences of patients with ITP. And the other main study really is the IWISH study, which some of you may have also taken part in, so that we get a better flavour of how patients are feeling and therefore how we might be able to optimise therapy, particularly if we try and understand the impact of the therapy on how patients feel as well as their ITP itself. Primary ITP is a rare disorder. Its predominant feature is low platelet counts, and it's caused by an autoimmune response to platelets, generally diagnosed when the platelet count is less than 100. And individuals can present with a variety of different signs of bleeding, from mild bruising to more severe bleeding, perhaps into the brain or the stomach. And the risk generally and severity of bleeding events increases when the platelet count is less than 30. But in addition to this, even when the platelet count's over 30, and even when patients don't have any significant bleeding, it can have quite a major impact on health-related quality of life, partly related to the ITP and partly related to therapy. Our treatment aims are to try and individualise treatment for patients, generally aiming for a platelet count of over 30. We're trying to minimise the risk of bleeding events and the consequences of those bleeding events. The role for corticosteroids is changing. There is definitely still a role, very big role for corticosteroids up front. However, we do recognise that these are not always very well tolerated, not necessarily a long-term solution. A substantial number of patients after a course of corticosteroids need to go on and have further treatment. And the use of the thrombopoietin receptor agonist as standard of care for those who relapse or are refractory to initial treatment for ITP is really now recommended in most of the guidelines, which are listed at the bottom of this slide. Actually, during the COVID-19 pandemic, we have been able to use the thrombopoietin receptor agonist first line if we felt appropriate, having canvassed NHS England for access to that, to try and avoid high doses of steroids and perhaps more severe COVID phenotype. But those patients would need to be negative for COVID-19 infection, because that COVID-19 itself can slightly increase the risk of thrombosis. We just have to be careful we don't make that worse. So at the moment, there are 3 main thrombopoietin receptor agonists that are licensed for ITP, although of those, only 2 are available in the UK. So at the moment, avatrombopag is not available routinely in the UK because it hasn't been through the standard NICE technology appraisal, but it is going through the standard NICE technology appraisal. So we hope we will have some news on that soon. Romiplostim is what's called a peptide molecule. It's a much bigger molecule than eltrombopag and avatrombopag. Romiplostim is given once weekly, whereas eltrombopag and avatrombopag are given daily. And romiplostim, whilst actually has the advantage of just a once weekly injection, does mean that patients need to learn to self-administer, which I think in the UK is great, because generally patients are very motivated to do so. In other countries, it's a challenge, and sometimes patients have to attend hospital weekly, partly through funding reasons as well, particularly in America. Eltrombopag, one just needs to be a bit mindful of food and medicines containing calcium, because it can reduce the absorption of the eltrombopag. Avatrombopag doesn't have any dietary restrictions at the moment. Sorry, it doesn't have any diet restrictions. And they're all very well tolerated. I mean, all medicines can have side effects, but generally speaking, we don't find that patients have too many side effects with these medicines. We do know that in some patients you can have an increase in the bone marrow, something called reticulin, and if that becomes quite significant, we have to stop the medicine, but the rates of that are similar across all 3. And similarly, potential thrombosis rates are the same across all 3, and we generally feel, I think, that this is related to the patient's risk factors rather than the medicine per se, but we're always a bit mindful of that. But other than that, essentially, very minor side effects, and generally very well tolerated and better than steroids. So the aim of the Trapeze study was to better understand the impact of different treatments on quality of life for patients, and more specifically, the factors that influence the preferences towards different agents and types of therapy. It was open to participants in the UK and Ireland between 18th of September 2020 and 18th of February 2021. And the participants were recruited by the UK ITP Support Association. This is being rolled out internationally and likewise recruited from other countries through the support associations. And there were two arms to the study, one around treatment preference and some clinical scenarios, understanding the preferences of TPO-RAs, and then one around kind of burden of disease for the patient, trying to understand the demographics, the disease characteristics, current and previous treatment, how satisfied they were with the therapy in various different domains, the kind of resource utilization and the wider potentially social impact. So in the UK, we had 32 respondents, 32 completed the first bit, and 31 completed to the end all the questions on patient burden. About 65% were female, with an average age of 57 years, but ranging between 21 and 83, so the full spectrum. The average age at diagnosis of the ITP itself was 48.7 years, and the average time since ITP diagnosis was 8.9 years. So quite a lot of patients had had ITP for a long time. On average, participants experienced 4 symptoms when their ITP was active, 4 symptoms at a time. The most common ones were fatigue, bruising, petechiae, which are the dots under the skin, and anxiety about the platelet count, but actually also unexplained nosebleeds, dizziness, prolonged bleeding from cuts, low mood, headaches, heavy menstrual bleeding featured. But it's interesting that fatigue actually is ahead of bruising and petechiae. As far as the impact on quality of life, fatigue and anxiety actually had the biggest impact on quality of life. And this does fit with what we know from the Irish study for what patients are telling us. But we also have kind of petechiae and some other medical symptoms coming into play that we can see. But actually these symptoms we can't see, the fatigue, the anxiety, the kind of worry that patients are under, I think is a big issue. And I think during the COVID pandemic actually has been an awful lot worse, because I think it is very difficult to understand the changes in accessing healthcare and the consequences perhaps even of COVID and vaccines, etc. Although this study was early on in that. And so I think this adds to the literature, and it is an important area for us to understand. There were also some questions about whether the ITP condition had changed since diagnosis, and whether things had got better, things had got worse, things had stayed the same. So on this slide, to the left, the green and light blue is significantly worsened and slightly worsened. Yellow is no change, and then the darker colours on the right are improved and significantly improved, with proportion of respondents on that. And we can see that actually about 52% of patients have felt their ITP had worsened since diagnosis. And overall, only 29% of things had actually improved, and then the rest kind of no change or weren't really sure. So again, I think over time, patients are clearly not always feeling significantly better. And actually, I think I was slightly surprised by those results, because we would hope that we were making patients feel better with how we manage them. And I do think this will be an important area to look into a bit more detail. But when we asked for a kind of overall health score on a scale of 0 to 10, where 10 is feel great and 0 is feel really terrible, the overall mean health score was about 7.3. This is just lists or shows the stability of the ITP condition in the 3 months prior to the survey completion, looking at kind of stable or unstable with platelet counts at different levels. So the vast majority of patients had stable platelet counts of over 30 with few or no adverse events, but there were some who did have platelets of less than 30 and some adverse events as well. So kind of mixture, but most actually had platelets of over 30. So looking at the treatments that the patients were on, it was about half and half romiplostim and eltrombopag, and average treatment length roughly the same in both. Wasn't really any significant difference, about kind of 2.5 years-ish. About 40% had switched TPO-RA, so 11 had received eltrombopag before then being switched to romiplostim, and 2 had received romiplostim and then were now on eltrombopag. And the reasons for switching are below: lack of response, platelet count fluctuation, loss of response, having responded, and an adverse reaction. So actually the vast majority being that they didn't actually respond in the first instance, or that the platelet counts were up and down a little bit. So this is a busy-ish slide, but shows prior therapies and concurrent therapies. On the left, we've got prednisolone, methylprednisolone, dexamethasone, so those are all steroids. And then moving on, we've got mycophenolate, rituximab, azathioprine, those kind of suppress the immune system. Danazol, dapsone are kind of the more traditional treatments from many years ago for ITP, but still can have a role. Fostamatinib, which is not routinely available in the UK, although has been available through clinical trials, and 1 or 2 sites have been able to access it for patients. And yellow is never taken those medicines, green is currently take, and blue is used to take. So quite a lot of patients have had steroids before. This adds up to more than 100 because they may well have had different types of steroids. Not many patients have had dapsone, danazol, fostamatinib, cyclophosphamide, but quite a few patients have had mycophenolate and rituximab before and clearly have switched over to a TPO-RA because they haven't responded. The thrombopoietin receptor agonists were felt to have good treatment effectiveness, but interestingly, only just under 20% felt that their energy levels had increased. So if we take each of these 4, we've got satisfied with the control of platelet production, that patients felt it was an effective treatment for preventing bleeds, it was an effective treatment for treating symptoms, and it was effective at increasing energy levels. Dark blue at bottom is strongly agree, and then strongly disagree, then orange is disagree, coming up to grey neutral, yellow agree, blue strongly agree, and green don't know, and brown I prefer not to say. You know, actually there are a substantial number of patients who do agree and strongly agree that the control of platelet production, that these agents are good at controlling platelet production and preventing bleed events. But you can see that actually there's quite a good number that don't feel that they feel better with energy levels. And I do think we should explore that more, because if the platelet count feels better, I think the assumption historically has been that actually things are much better for the ITP, but that may not be the case, and I think is actually quite interesting information. There are some concern about side effects. So this is worried about short-term, long-term side effects. And although generally speaking, I think patients are happy with them, there's still obviously a little bit of a worry about the side effects in the background, and that would be the same for any medicines, particularly those that we have to take long-term. But most patients did very much value that their immune system wasn't suppressed. Looking at the tolerability of these medicines, we asked questions around whether the treatment required changes to the daily routine, whether it required treatment to diet, whether patients were easily able to stick to the treatments, and whether patients would recommend the treatment to another patient. And generally speaking, I think there were concerns around changes to daily routine. We didn't really ask why, but I think if you're taking a medicine all the time or having to remember to take something once a week, then obviously there is that kind of conscious, have I taken it? Do I need to think about it? With Ultramilk, obviously, you know, have I taken it with my cup of tea and avoided milk? And the injections, just thinking about the timing of that and how that's going to work, and just having the time, the space, the bandwidth to prep an injection, make it sterile, etc. The patients obviously found that those that were on Ultramilk had to change their diet, but those that weren't didn't. And so the majority didn't find too many issues. Most patients found it very easy to stick to the treatments. I think that's a credit to ITP patients who actually are very engaged with their therapy. And we find actually very few issues with patients not taking their medicines at all. And actually, encouragingly, most would recommend this treatment to another patient. And I think peer advice can be very helpful. You know, the document, the treatment decision-making tool that's been developed by the Sport Association, our patients have found super helpful. And I think peer support is very helpful for understanding, you know, you've been there, you've done it, and some reassurances to other patients that, you know, we've tolerated this, there are some concerns, but on the balance, we feel well on it, and we certainly would recommend it going forward. Then had a look at what preferences patients would have, the kind of attributes, the features of the treatments, and looked at need for monitoring, frequency of dosing, platelet count response, potential side effects, how it's given, and the need to change diet. And generally speaking, patients were 5 and 3 times respectively more likely to select a treatment based on mode of administration or potential for interactions. And that could be either way. Some patients, very much felt that they didn't want injections. Some patients felt very much that they didn't want to have to think about what they were eating and what they were drinking and making the timings. And I think, it's great to have the choices for patients available. Sorry. So to kind of summarize the Trapeze study, this is additional helpful data we hope to back up what's been said before about ITP, about the quality of life and how it's affected. Fatigue still appears to be a persistent symptom. It is quite difficult to manage, and in some patients can be refractory to therapy, and that is interesting to try and understand what it is. We've been trying to do some work to look at accessing funding for psychological support for patients with ITP. And I think this is patchy. I think some areas are able to access that. Some areas it is more challenging. But I would like to see if we can a move to discuss that more formally, because I think it feeds into also that patients can feel quite anxious about platelet counts, particularly when your appointment's coming up. And I wonder also whether the anxiety also feeds into the generalized fatigue. So it's helpful to have this information going forwards as we try and look at how we can get psychological support. The thrombopoietin receptor agonists are commonly used in ITP, and switching between agents is common practice. And the switching between agents could be because the drug wasn't working, or because platelet counts were fluctuating, or the platelet count or the drug stopped working, or actually, patients felt that the mode of administration, they needed a change. And the general drivers of patient preference, as probably we would anticipate, were dietary restrictions and mode of administration over anything else really, as far as monitoring platelet counts and things like that. So just to say thanks to the co-authors and the others who worked on this study, to say a huge thanks to the Sport Association for taking this forward and giving the patients the opportunity to take part in it. I think it's a very forward-thinking organisation in that respect. There's the kind of main title of the paper that has now been published. And thank you very much for listening, and hope you're enjoying the Sport Association weekend. Thanks very much.